All right, so let's go through this chest radiograph of a skeletally mature patient. The first thing I'm seeing is the presence of multiple rounded opacities in both lungs. These opacities vary in size, and they're scattered across both lung fields. This distribution makes me think of metastatic nodules. Large pulmonary nodules like these are concerning for metastasis, especially given their widespread nature. Moving on to the bones, I can clearly appreciate widespread bony sclerosis. The bones are much denser than normal, and this doesn't seem to be a case of underpenetration of the film because the lungs are of normal density. This tells me that we're dealing with true bony sclerosis. Now, when I see this combination, diffuse bony sclerosis and multiple pulmonary nodules, the first thing that comes to my mind is metastatic disease. In a male patient, I would strongly consider metastatic prostate cancer. Prostate cancer is well known for causing osteoblastic or sclerotic metastases, and it's a classic presentation in men. The diffuse bony involvement we're seeing here is very characteristic. Although prostate cancer metastasizes to the bones quite frequently, pulmonary metastases are less common but can coexist, which is what we could be seeing in the lungs. Now, if this were a female patient, we'd need to think about metastatic breast cancer. Breast cancer can also cause sclerotic metastases, though lytic metastases are more common. The absence of visible breast shadows on this radiograph could indicate a history of mastectomy, which would strengthen the case for metastatic breast cancer. Looking for other potential causes of diffuse bony sclerosis, we also need to keep in mind other neoplastic causes like hematological malignancies, such as lymphoma, or even rare conditions like osteopetrosis. However, the combination of large pulmonary nodules and diffuse sclerosis makes metastatic disease much more likely in this case. It's also important to rule out metabolic causes. For instance, renal osteodystrophy associated with secondary hyperparathyroidism could result in diffuse bony sclerosis. If the patient had renal failure, we might also expect to see other findings like soft tissue calcifications or a dialysis catheter. But without those features, I think we're more likely dealing with a neoplastic process. So, given the findings here, diffuse bony sclerosis and multiple pulmonary nodules, the most likely diagnosis would be metastatic prostate cancer in a male patient or metastatic breast cancer in a female patient. The next steps would include reviewing any previous imaging, particularly bone scans, which could show a superscan appearance, meaning diffusely increased radionuclide uptake throughout the skeleton with reduced renal and soft tissue uptake. This is a nonspecific finding often seen with widespread osteoblastic metastases. Now, anticipated questions from the examiner might be something like, what are your differentials for diffuse bony sclerosis? In this case, I'd emphasize that while metastatic prostate cancer is the most common cause in men, other differentials include metastatic breast cancer, renal osteodystrophy, and esoteric causes like osteopetrosis or Paget's disease. They might also ask, how would you distinguish between these causes on imaging? For metastatic prostate or breast cancer, you'd look for bone scans showing osteoblastic activity and possibly other signs of the primary malignancy, like lytic or sclerotic lesions. For renal osteodystrophy, you'd want to correlate with clinical signs of renal failure, soft tissue calcifications, or the presence of a dialysis catheter. For rarer causes like osteopetrosis, you'd expect a more homogeneous pattern of bone sclerosis. Finally, I'd expect them to ask, what further investigations would you suggest? My answer would be to recommend a bone scan to confirm widespread osteoblastic metastases and a CT scan to further characterize the pulmonary nodules and look for other sites of metastasis. Clinical correlation with PSA levels or breast cancer markers would also be useful in narrowing down the primary source. To wrap this up, based on the imaging findings and probable clinical context, metastatic prostate cancer with skeletal and pulmonary metastases seems the most likely diagnosis here in a male patient, while metastatic breast cancer would be the likely alternative in a female patient. If you enjoyed this case and want more radiology insights, don't forget to subscribe to Radiology Made Easy. Let's keep learning and making radiology easier for everyone.